Okay, so our second AML expert is Dr. Amanda Przespolewski. Dr. Przespolewski treats patients with both malignant and non-malignant blood disorders. This includes patients with acute myeloid leukemia, acute lymphoblastic leukemia, myelodysplastic syndrome, and chronic myeloid leukemia, and myeloproliferative neoplasms. Her research interests include early phase clinical trials for high-risk myeloid malignancies, as well as translational medicine. Her translational work is focused on understanding how leukemic blasts modulate the local immune system to evade detection and therefore identifying new therapeutic targets. Dr. Przespolewski is currently working on over 30 active clinical trials. Thank you so much for being here today with us, Dr. Przespolewski.
Hello. I would like to thank HealthTree for inviting me to be here with you today. So the topic that we're going to be discussing this morning is what if I relapse after transplant? And these are my disclosures. So today we're going to be reviewing what are some risk factors that could put you in the position to possibly relapse after transplant. What are the recommended monitoring strategies for following your disease after transplant? Is there anything that we can do in certain patients to possibly prevent or delay relapse? And then what are some treatment options that we consider if we find that you have relapsed after a bone marrow transplant? So as we just heard from Dr. Wang, not surprisingly, the amount of disease burden present in the bone marrow prior to undergoing a bone marrow transplantation correlates with
Dr. Przespolewski, I'm so sorry, but the screen sharing, it didn't go through, so we're not seeing your slides.
How's that?
That's great.
Sorry,
Thank
forgot
you.
to hit share.
That's what I forgot too. Thank you.
So as I was mentioning, the risk of relapse is predicated on one factor in particular, how much disease is within the bone marrow prior to undergoing a bone marrow transplant, as well as MRD positivity. MRD should absolutely be tested in all patients prior to bone marrow transplant. And as you can see here, this is data represented from a meta-analysis that essentially demonstrated no matter how MRD is detected through PCR or by flow cytometry, if it is present prior to undergoing transplant, unfortunately that is associated with worse outcomes, including earlier relapse after transplant. In addition, identifying your MRD status prior to bone marrow transplant is important because, as Dr. Wang was mentioning, there are some therapies that are undergoing clinical evaluation via clinical trial to try and eradicate MRD positivity prior to undergoing a bone marrow transplant. So in addition to your MRD status, the disease risk stratification prior to bone marrow transplant is an important risk to determine whether or not your leukemia has a higher chance of coming back. Within this study that I have here, patients were classified as either having favorable risk or poor risk, depending on their cytogenetics prior to bone marrow transplant, as well as patients with a complex karyotype and monosomal karyotype were characterized as having poor risk disease. So patients that had favorable risk and ended up undergoing bone marrow transplant had a 2-year relapse incident, as well as a leukemia-free survival rate of 72%. However, patients that had poor risk disease, unfortunately, their 2-year relapse incidence rate was more than double what was seen in patients with favorable risk, and their leukemia-free survival, unfortunately, was less than 20%. So in summary, your risk group prior to undergoing bone marrow transplant, as well as overall disease status, including overt evidence of disease, and being MRD positive are unfortunately associated with a higher risk of post-transplant relapse. And in addition, patients that had possibly achieved a complete response and a cure and then had a second relapse, those patients were found to do poor after undergoing a bone marrow transplant for the first time in their second remission. So as far as monitoring for AML patients post-transplant, they should undergo routine monitoring with more than one modality for MRD, possibly flow cytometry, as well as PCR if target mutations are available to follow, to ensure that there's adequate sensitivity to detect a recurrence risk. And because of the polyclonal nature, heterogeneous nature of the disease, as Dr. Wang had spoke upon, an individualized approach should be formulated for each patient. And as I mentioned, so this is why we recommend using a tailored monitoring strategy, and it's also important to follow what's called chimerisms post-bone marrow transplant, because if we see changes in the chimerism, which is essentially the new donor hematopoietic compartment, that could indicate an impending relapse as well. So there are some therapies right now that are being employed to reduce the risk of a post-transplant relapse. An example of this is therapy directed for patients that have FLT3-ITD mutated AML. So the SARMAIN study was a randomized, double-blinded, placebo-controlled phase 2 study that evaluated the FLT3 inhibitor sorafenib as maintenance post-transplant. So within this study, 83 patients with FLT3-ITD mutated AML were randomly assigned either sorafenib, the FLT3 inhibitor, or a placebo maintenance for 24 months after completing a bone marrow transplant. So you can see here the relapse-free and overall survival in patients that were FLT3 positive in complete remission after their bone marrow transplant, treated with either the FLT3 inhibitor sorafenib or a placebo. So in Figure A, on the left-hand side, you can see the relapse survival in the patients that had received sorafenib in the blue line, as well as the patients that had received placebo in the red line. So in total, 29 relapse-free events were recorded, 10 within the group of patients that was receiving sorafenib, and 19 in the patients that received placebo. And on the right-hand side, you can see the overall survival for patients treated with either sorafenib or placebo. And there's a significant difference in terms of improved survival for those patients that received the FLT3 inhibitor compared to those receiving placebo. And lastly, you can appreciate the impact of FLT3 inhibitor therapy on patients within this study, and that's most pronounced in patients that were MRD positive prior to undergoing bone marrow transplant. So in those patients that went on to receive the FLT3 inhibitor with sorafenib in panel C on the bottom left, those patients had improved relapse-free survival compared to those patients that were MRD positive and only went on to receive placebo. So one of the other important points that's critical to consider post-transplant is especially in patients that have higher risk disease with some of the factors that we discussed earlier, such as being FLT3 positive or having a complex karyotype, or were MRD positive and were unable to be rendered MRD negative. If it's clinically appropriate, meaning that there's no evidence of active graft versus host disease, we try and work with our bone marrow transplant colleagues to rapidly taper the immunosuppression for those patients. Because the immunosuppression is important for keeping the graft, but sometimes if we're suspecting a high chance of relapse, we want to take away that immunosuppressive treatment to try and permit the graft to grow and to carry out its intended anti-leukemic effects. And this can also restore donor hematopoiesis if we see changes in the blood counts or changes on the chimerism testing. So what are other options for our patients that are at high risk for relapsing post-transplant? So there are some targeted agents that are currently under development in terms of being evaluated through clinical trials. For example, patients that have FLT3 disease, we currently have a clinical trial evaluating the novel FLT3 inhibitor crenolinib that is permitting 24 months of maintenance post-transplant with that agent, as well as the IDH1 and IDH2 inhibitors are currently being studied in clinical trials, as well as the role of the BCL2 inhibitor Venetoclax. More recently, we have a couple of clinical trials here, particularly at Roswell Park, trying to modulate the graft to be even more efficacious in its anti-leukemic activity by employing cancer vaccine, for example. So what if, unfortunately, we do find that you relapse post-transplant? What are the options? So prior to deciding on a treatment, I think it's important for patients to assess several things. What are your treatment goals? How are you feeling after a bone marrow transplant? Do you still feel like you have a good quality of life? Or have you unfortunately had some complications that may make you feel a bit weaker than when you had undergone the transplant? What do you want your quality of life to be like? Is time important to you, which can sometimes affect quality of life if we have to use more aggressive strategies, or is quality of life important to you? And do you also have a lot of support to embark on another round of treatment? Some of the factors, unfortunately, that we can't control for, but are important in determining what treatment options we have, are patients' age, and more importantly, how are they functioning after bone marrow transplant? After transplant, have they acquired additional health problems? Did they have negative effects on their kidneys or their liver or their heart as a result of undergoing bone marrow transplant that could affect what treatment options may be best suited for them? And as I mentioned, performance status. How fit are patients after undergoing a bone marrow transplant and then at the point when they relapse? So I think first and foremost, clinical trials are very important to consider in this particular situation. Because in addition to taking into account some of those variables that we just reviewed, there technically is no standard of care for patients that have relapsed post-transplant. So if there is a clinical trial available to you or available at a neighboring center, I would strongly encourage you to look further into that and to discuss that with your physician. So in addition to some of the resources that we heard earlier are available through HealthTree, this is the clinicaltrials.gov website, which is available to anybody who wants to access it. And you could put in what your age is, what kind of a disease do you have, and in this setting, we would be looking for post-transplant relapse for AML, and it will come up and populate all the clinical trials that would be available to you that are accruing. So one of the therapies that comes to mind for us in somebody that's relapsed is something called donor lymphocyte infusion. So essentially what this is we try and give treatment. Typically it's azacitidine, one of the hypomethylating agents, to try and reduce the disease burden. And we also think in this setting it can possibly help the cancer express some of the proteins that allow the immune system or the graft to detect it as foreign. So after 2 cycles of azacitidine are administered, we would go back to the donor who donated for the patient who relapsed for their bone marrow transplant to collect additional lymphocytes to then infuse to the patient, usually approximately 6 weeks after their last dose of azacitidine. And then we take another couple-week break to allow those lymphocytes to be incorporated within the bone marrow. And then we go on and sandwich in additional azacitidine. So this kind of a treatment option is available for patients if they don't have active graft versus host disease, because we wouldn't want to give additional donor lymphocytes, which could potentially make the graft versus host disease worse. And we would also have to have the donor available to give us additional lymphocytes for a treatment in this setting. Additionally, this seems to work better in patients with lower level disease, such as becoming MRD positive or having a very, very low level relapse. Patients that have very overt disease, unfortunately, represents disease that is often fast-growing, and those patients are really not a candidate for this type of therapy, as it doesn't seem to work as well. So in patients that have FLT3 disease and relapse post-transplant, one of the agents that has recently become FDA approved is gilteritinib, and that's a FLT3 inhibitor. So within this phase 3 study, patients were randomly assigned to receive either FLT3 inhibition with this agent gilteritinib versus what we would call standard salvage chemotherapy of the investigator's choice. So within this study, there were 371 eligible patients. 247 were assigned to receive the FLT3 inhibitor gilteritinib, and 124 patients were assigned to receive salvage chemotherapy. So the median survival in patients with gilteritinib therapy was significantly longer compared to patients that had received standard chemotherapy. So in this setting, if patients do relapse with FLT3 positive disease, we would want to ensure that their therapeutic strategy that we're using to target those patients goes after that particular mutation. Similarly, in patients that have IDH1 mutated disease at relapse, they could be eligible for standard of care with the IDH1 inhibitor ivosidenib. So as you can see in the red rectangle, patients that had refractory or relapsed AML, 30% achieved CR or CRh, and the overall response rate in these patients was approximately 40%. So this is a potential option that would be considered standard of care in patients relapsing with IDH1 disease. Similarly, in patients with IDH2 relapse, patients can be treated with the Idh2 inhibitor enasidenib. So in this particular clinical trial that was published several years ago, the overall response rates for patients with R140 IDH2 mutations was approximately 35%, and patients that had the R172 IDH2 mutation had an overall response rate of approximately 53%. So this does represent an effective strategy to consider in IDH2 mutated patients. So one of the newer standard, I shouldn't say standard, but one of the more frequent approaches that we're seeing in patients that have post-transplant relapse that don't have a targetable mutation, and those patients that are not eligible for a clinical trial, one of the strategies that we sometimes employ is azacitidine and venetoclax, particularly if patients were not treated with that type of a backbone prior to undergoing bone marrow transplant. So there was a study that was published looking at patients that had relapsed post-transplant. It was a small single institution study looking at 29 patients, and they found that the overall response rate was approximately 38%. And it seems to work in the cadence that it does in the upfront setting. So the median time to complete response was about 2.5 months, which would be approximately after 2 cycles. And in those patients that did respond, the median duration of response was approximately 7 months. And here you can see that the survival and leukemia-free survival was significantly prolonged in patients that did respond to this type of a salvage regimen. Now, we can also consider more aggressive salvage chemotherapy. Some regimens include CLAG, FLAG, MEC, but I think that those types of regimens are for very specific patients. So ideally, I think it would be useful to employ regimens with this type of intensity and backbone in patients where it had been a year or two since they had received prior induction, which would typically be consisting of a 7+3 based regimen. Because in patients, for example, sometimes they relapse 3 months post-transplant, and if they had just gotten 7 and 3 and went through a transplant, I don't know that therapies with a similar type of mechanism go after the leukemia cells would be effective in that particular situation. So in some patients, if they're very fit following a treatment for their leukemia after transplant, and they're lucky enough to have another donor, some patients are considered for a second allogenic transplant. But in those patients, they should have a good donor available. They should be very fit, as I mentioned. They should also ideally be MRD negative. So some of the resources available to patients and their families include HealthTree, the Leukemia Lymphoma Society, and the NCCN guidelines also has a patient education section that I think is useful for patients and families to review. So what I'd like for you to take away from today is that you should ideally be an informed patient. Know your disease status, know your risk status prior to transplant and after transplant. What is your MRD status? And also understand what treatment options you have in the post-transplant setting, whether or not there is disease and if you do relapse. And I also think it's important for patients and their families to identify what their treatment goals are so that their provider can select the most appropriate regimen based on their goals. I also encourage you to use some of the resources that we discussed today and to make sure that you surround yourself with as much support as possible. Thank you.